Good morning, everyone. I'm going to give it a second as we still have a couple of folks joining, but I am definitely of the mind that if something is called for 10 o'clock and you're not here at 10 o'clock, then we're starting with or without you. So for the 31 folks that are here right now and we're continuing to grow, we'll give it just until 10:01 and then I will begin. Hope everyone's having a great day. I'm out on the East Coast, and today we woke up to very crisp fall weather. We've got a freeze warning for tomorrow morning. So I had to pull all of my last tomatoes in last night and try to get those to ripen inside. We're at 10:01 now, so I am going to start us off. This is the second session of our performance improvement boot camp, how market insights drive rural hospital performance. My name is John Downs. I'm a principal and director at Stroudwater. Have been here for just over 15 years now. My areas that I really focus on are market analytics, what that means relative to volumes, strategic planning, and then facility results as after we understand the strategy and the volumes. Together with Wade Gallen, we'll talk about how we can use those market insights to drive performance. Wade, tell us about yourself.
Oh, where to start? Well, from a professional perspective, I have a background in reimbursement and finance. So, really, what I do for Stroudwater, I've been with the firm about 4 years at this point, and I help with really the financial side of strategic initiatives within rural hospitals. So, helping to translate, we have a great strategy, we have great plans, and how does that translate to our financial side of the house, and how can we make it viable financially? So, good to be on here and to discuss this really important topic.
Awesome. Thanks, Wade. So we've got a 6-session series. Those of you that were with us last, I believe it was Friday, heard Eric Schell kind of give an overview of all of the different pieces that we look at when thinking about performance improvement. It was a presentation that I've heard many, many times, and many of you have probably heard it in similar forms. But it really started to drill into some of the core components of performance improvement. Today, we're going to do the second session, which is really thinking about how do we reduce the leakage in a market? How do we try to grow share and keep care local? Because that's got a significant piece of that performance improvement opportunity. Wade, do you want to tell us about the other sessions?
Yeah, so I have the privilege of doing a cost report deep dive session that will actually be following this presentation on a different Zoom link. So hope to see some of you all there as well. Really going to be going over the Medicare cost report at a very high level and identifying some of the common opportunities we see when reviewing rural hospitals. So that'll be a great session. And after that, we have a number of other great presentations in the lineup, including a swing bed boot camp where we're going to go over really, what a swing bed program can be, what are some of the opportunities there, practical insights and regulatory requirements of swing bed programs, which is obviously an important opportunity for rural hospitals. 340B, we're going to take a deep dive into that, really understanding there's so much that's changed in the 340B program as of late. And so it's important for us to maybe remember some old things, but also understand what the new realities are for 340B and how do we maximize that. So that'll be a great session as well. And then we have a revenue cycle deep dive, which is revenue cycle continues to be one of the highest priority opportunities we see for rural hospitals as well. So this will be a great deep dive session into that area. And just to provide a little bit of context for the PI bootcamp and the reason why we broke down and dug into those specific topics was because we did an analysis of roughly 30 rural hospitals that we had worked with in the past couple of years to identify what were the most meaningful opportunities we found after doing a strategic financial and operational assessment. And there were some clear winners that came to the top of that. We have a few areas such as reduction in outmigration for inpatient services, service line growth and expansion. Those are the two that we're going to focus on today. Revenue cycle, swing bed, 340B. Again, these are all the areas that we're trying to cover in this this performance improvement bootcamp, because again, we found them to be quite meaningful from a financial perspective, and we want to make sure we're maximizing these opportunities in an environment where margins continue to be difficult to maintain, right? So we wanted to focus on what are the high impact items that we can bring to the table.
Yeah, and the two that we're talking about today, that inpatient outmigration and the service line growth or expansion, those represent about 50% of what we've identified in these performance improvement engagements. So really kind of looking at that low-hanging fruit and saying, how can we begin to think about our market in a way that starts to size it so that we have an understanding of what we could bring in, perhaps of things that we're already doing. So learning objectives today, I was told whenever you do a presentation, we're supposed to tell you what we're going to tell you. So, want to start by understanding how to evaluate the market opportunity. Some of you may have seen some of the market assessment or strategic planning presentations that I've given. The slides will be very similar to those, but it's really important for us to think about how we identify the market before we start to look at what's actually happening inside of it. Then Wade's going to really help us think about how we can calculate the value of capturing some of those low-hanging pieces of fruit, growing the share of things that we're already doing. And importantly, we'll talk a little bit about differentiating needs versus wants. I'm sure many of you hear, oh, we want this, we want this, we want this. Well, is there really the demand for that in the market? So it's important to look at that. And then identify when new services make sense to consider. Again, just because a board member says we should offer X doesn't necessarily mean that you should offer X or that you're going to be able to offer X and make that financially viable. So we've got to think about the market volumes, the staffing requirements, and the facility requirements to make that happen. I always start virtually every presentation I give with this slide because I think there are 4 levers to calculating market opportunity. This doesn't matter if you are a critical access hospital in a 3,000 person service area or you're Mass General and you've got a couple million people that are, available for you to serve. It starts with the population. What is the population that you're serving? Understand the geography, understand what that size is, understand what's happening in that market. Are we aging? Are people moving in? Are people moving out? Are people dying out? Are there special populations that we have to think of? Oftentimes we've got a university that might be near us, and some of those students may use our services, but are they part of our market? Or are they technically captured from a utilization perspective in the home market of their parents where their insurance might be? Once we understand that population, then we start to look at the rate at which people utilize the services, and that gets driven by a whole bunch of things, whether we're doing population health strategies. Hey, let's keep people out of the emergency department. Let's not overutilize diagnostic imaging modalities. Maybe insurance is telling us something. Maybe we're trying to drive down readmission rate because that's been high and we're working on bringing that down, or things are shifting to the outpatient side. Those 2 levers we don't have a lot of control over. We have a little bit more with utilization, certainly, than population. Where we get more control is on the market share side. Right? Are we in the game? Are we not in the game? Most critical access hospitals not opening a transplant program. So we're going to take 0 market share on transplant, but I'd sure like to get closer to 100% market share in the emergency department. And while we can have some control over that, there are others that are looking to control some of that too. Our competition, insurance companies steering folks away from us, primary care providers that might not be aligned with us and instead shifting things to other providers. Affiliation strategy. Do we have a system parent? Are there large systems around that are pulling patients out of our market? And then the final one, and we're not going to talk about it much today, is on the throughput side. That's the one we have the most control over. How often are we open? Are we a 7-day, 24-hour shop? Or do things close down at 4 o'clock on Thursday and we've opened them back up on Monday from an outpatient perspective? Throughput really gives us the opportunity to think about how much volume can we put through a fixed set of assets. Because our hospital is there 24 hours a day, we do have the ability oftentimes to capture more volume without adding additional capacity just by changing some of those throughput levers. So we start with that population. Really, what is our real service area? And so many times when we think about service area, we'll come onto a project and client says, here's my service area. I'm in a district or I'm a county-owned facility. And so that must, by definition, by executive fiat, be my service area. That's fair, and we can certainly evaluate that. But it's also important for us to think about, is that our true service area? Are we the dominant provider of inpatient or outpatient services in that service area? Should we subdivide it? Sometimes we get really, really big service areas that just don't make sense to look at as one entity. Maybe we want an east and a west. We want a primary and a secondary. We want a whole host of different ways to look at that. Particularly as we think about expanding services off of our main campus, we may be growing new services. So sometimes we ask, who does the project benefit? Right? If we're putting something out into a further community from the main campus, perhaps the service area is growing. It's not benefiting my core county. That is, remember our executive fiat. We must stay within that county, or we must provide services in that county. Perhaps there's another group that's benefiting from an individual project. When we understand that service area, kind of, put a big fence around the outside of the service area, now we want to know everything that's happening inside of it. What's happening from a population projection perspective? Are we growing? Are we shrinking? What's happening from an age perspective? Many times in rural communities, we're seeing, an aging population. We don't have a lot of 0 to 17 growth, but we have a whole host of 65 plus growth inside of those areas. And I mentioned before some of those special groups. Are we near a university? Do we provide services to a local prison? What's happening inside of the market? Do we have new housing starts that may not even be considered in our baseline population projections? Do we have tourism that we've got to be able to deal with? All of those are important demographic components so that we can understand what is the future demand for those services in our community. Once we understand the population, we understand the demographics, then it's about understanding how things are getting utilized. We start with our existing volumes. What piece of the market are we capturing today? What do we have from an inpatient versus an outpatient perspective? What are the service lines we're offering today? And what exists in the market for us to offer if we wanted? And what piece of the things we're doing do we capture? What is our market share? I'm going to share a couple of graphics in a second to talk a little bit about that. The other thing to think about as we're talking about trying to identify opportunities for growth in our market is understanding with whom we compete. Oftentimes, we might be the only hospital in the service area, but there are other hospitals that are taking some of that kind of community hospital or specialty care out of our community and bringing it to their facilities. So we have to be realistic about we're not going to capture 100% share in all of our services. The retail marketplace is also growing in many of our communities. We saw a huge influx several years ago of folks opening urgent care centers. Urgent care was originally designed, hey, we're going to take people that aren't emergent out of the emergency room. What did it really become? I think it became kind of a substitute for the lack of primary care that we often had in our communities. Instead of just taking non-emergent patients from our ER, these were folks that were filling the gap that we couldn't get in to see a primary care provider, and I wasn't established with a provider, so I'm going to go to the urgent care. And provider groups, oftentimes, if we're not very well aligned, we might be competing with them, particularly on some of the ancillary services that we might offer. So now kind of digging into how we start looking at a service area, the best way, in my opinion, is not to work via the executive fiat or just because this is what we've always been. Instead, look at your actual patient data. Oftentimes, we'll look at that and say, traditionally it was 75% of inpatient discharges. Well, as a critical access hospital, as a rural hospital, oftentimes we're not major players in the inpatient game. And so we might want to become more of a player in the inpatient game. So thinking of it just from an inpatient origin perspective in defining our service area, I think oftentimes doesn't really give us a true identity. I think the best way to look at it, starting point, is emergency department patient origin. This was a client in upstate New York where we worked with them and said, okay, great. They did 24,000 ED visits. And we just said, can we get those ED visits by zip code for the last year? We're able to do that. And in their case, 84.7% of all of their ED visits were generated from what they originally considered their primary service area. That makes a lot of sense to me. 66.7% were from the community where the hospital is located. This isn't a critical access hospital, it's a smaller PPS hospital, but that gave us a sense that yes, we were in fact talking about an accurate service area for that. Could we have taken one community out or another or add another community in? Sure, we could do that, but it didn't necessarily make sense in the case of this client. Once we've identified that service area, now we want to understand it on a map. Okay, in this particular example, there are 3 communities inside of this service area. There is no hospital other than our client sitting inside of the middle of that service area. And now we can start saying, what do we need to understand about it? Right? What's the geography of it? How can we get from place to place? How easy is it for patients from each community to get to where we have our assets? We look at the population inside of that service area. In this particular case, relatively large population, 33,451, critical access hospital, projected to grow over the next 5 years by 2,254 people, 6.7% change over the next 5 years. So again, very different than many of our rural communities where we see population declines. This is a rural community with growing population. What do we want to know about that population? But one of the things we want to know is how does the age breakdown work and where is the growth there? Again, atypical for many rural communities, we're seeing growth in the 0 to 17. So there is childbirth happening in these communities, but we're seeing massive growth in the 65 plus age cohort, 19.1% projected growth over the next 5 years. And we think about the 2,200 total people that are growing in the community, 1,100 of that growth is coming from that 65 plus age cohort. Who utilizes healthcare resources more frequently? The people in the 65 plus age cohort. The other thing we want to understand is of those communities, how does the population break down between them? And so, the middle community here, 17,600 of the 33,000. So over half of those patients are from that single community, the single zip code. And then to the east and the west, there are other communities, one smaller, one a little bit larger, but that makes up their service area. Does not mean that when we look at our volumes or we look at our opportunities that we wouldn't accept people from outside of that. But this is really our core market. It's more realistic for us to think about capturing larger shares of a smaller geography than it is to think about capturing smaller shares of a larger geography. We have more control the closer we stay to home. Other detail when we think about demographics is also helpful. Understanding socioeconomics, understanding the income distribution. If I've got a very affluent community or affluent communities, then transportation tends to get easier. Also, choice tends to be easier because I can go to other places other than you. So I can go in or I can come out in order to seek that care. Insurance coverage. Where are we relative to our Medicare, our commercial insurance, our Medicaid? What's projected to happen as we see folks come off the Medicaid rolls? Will we see a growth in uninsured? What might that mean for our service offerings? And then finally, understanding kind of health status. Looking at some of the CDC health status indicators, healthy communities indicators, in order to say, hey, these are needs inside of our market. Oftentimes we've done, hopefully, our community health needs assessments. That's an opportunity to bring some of that information forward as we look at the services that we need to be offering. So if we remember that slide that Wade showed in the very beginning, 33% of performance improvement gains in that example of 30 facilities where we've done these analyses for were from preventing inpatient outmigration. And so if we want to do that, the first question is, well, what's the market look like, right? Is there enough inpatient outmigration or inpatient volume at all for me to keep? So we have to understand how many discharges and days are estimated in the service area. What are we realistically able to keep? Do we offer all of the service lines? Not necessarily in person, but do we have virtual connections to cardiologists and neurology and those kinds of things so that we can keep some of those patients? What's our acuity like? What are we able? Do we have an EICU? Do we have a hospitalist? Are we just having, some communities, we just have a family practice doc, or we've got an APP on the floor, and maybe the ER providers aren't that comfortable admitting to the inpatient unit. So we have to understand that acuity and the staffing competency, both on a nursing and a provider perspective. Do we have the space to accommodate someone, or are we at capacity today? Worked with a client in Washington State that was a 10-bed facility. Well, they outgrew their 10-bed facility. They couldn't keep inpatient. The volume was there. They had a lot of outmigration, but there was no room at the inn. So we needed to expand in order to keep those folks there. The other question to ask ourselves is, why are we not admitting patients to our hospital? Sometimes never had the chance. EMS took them someplace else. They didn't come into our hospital, wasn't even on our radar. We didn't know they existed. Sometimes the patient says, no, 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 I am not going there under any circumstance. Don't take me. I'm going to go someplace else. Maybe the provider says, you know what, you shouldn't go to XYZ hospital, go to ABC hospital instead. I'm going to admit you over there. Or, as I mentioned with that project in Washington State, sometimes we've got capacity constraints or perceived capacity constraints. Every time I go to the emergency department and I've had to be admitted, you transferred me. That to me says your capacity either of the ability to accommodate my acuity or the bed that I need to be sitting in, those are constraints for me. So when we think about that primary service area, the first piece is to understand the demand for inpatient discharges. And we want to look at those in terms of the various service lines, because we could say, all right, we don't do orthopedics. We're going to pull orthopedics out. So while this market estimates 3,000 discharges and 15,500 patient days, and is projected, even with a growing population, projected to decline on the inpatient side for acute discharges, we may say we want to pull 354 orthopedic cases out because we're not offering orthopedics, or we don't offer any surgery. So we're going to take orthopedics out. We're going to take general surgery out. We're going to take cardiovascular thoracic surgery. Maybe it's just an acuity issue. So sometimes we'll look at things and say, let's limit our acuity to only a case mix index of 1.5, right? Anything under 1.5, we can keep. Anything over 1.5, we're not going to keep. That doesn't put a hard line in medical and surgical. Just, it's an arbitrary number. But that decreased our total market from about 3,000 down to 1,700 discharges or 7,000 patient days. Now, those lower acuity days, as we would expect, projected to decline even more because those are the folks that are more likely going to observation status. And this is only talking about inpatient acute. However, in this market, if we were to put a big fence around the outside of these three communities and said anybody with a case mix index of 1.5 or below goes to us, we would estimate 7,084 patient days, which is an average daily census of 19.4. If we look at our actual census and it's 10, there's some low-hanging fruit there of low acuity volumes that we might be able to keep. Now the question for us is, how do we go about doing that, and what are the opportunities? So how do we add them? First, I'd say grow appropriate ED volume. If we're not capturing, we'll talk specifically in a bit about emergency departments, but if we're not capturing ED volume in the first place, we are going to have a much more difficult time getting increased inpatient discharges or inpatient admissions, because the vast majority of our admissions are coming via the emergency department. Unless we've got, a same-day surgery program where you're arriving in the morning and staying overnight, you are getting admitted. In general, most of our admissions are coming via the emergency department. Once they're in the ER, and Wade will talk about this in a bit, we want to maximize the appropriate ED admissions, right? Do we have, of our ED volume, we're admitting 3%, or are we able to admit more than that? We'll talk about some benchmarks. Making sure that our staff, if the ED is the door to potential admission, then we need to make sure that our ED staff is comfortable with the capabilities of the providers on the floor. Sometimes it's the same person, right? It's provider A is going to admit them and then go see them on the other side, and they know the nursing staff and everything is great. Sometimes it's two different groups, and there may be one group that isn't that comfortable with the other group. We had a client in Louisiana a couple of years back where we looked at the ER admissions by just overall, we said, oh, the number was really small. I think we wanted it to be somewhere between 10 and 12%, and they were about 8%. But when we looked at it more granularly, they actually were at 12% one week, then dropped to 4% the next week, then went back up around 12 the week after, and then back down to 4. And it was that there were two different providers in the emergency department, one of whom was comfortable admitting, one of whom was not, and they worked a week on, week off, week on, week off. And that itself, once we were able to fix it, dramatically increased the comfort or the number of discharges and admissions on the inpatient unit. Also, telemedicine, remote monitoring, support where appropriate to keep patients in-house. If we find ourselves not feeling comfortable to keep someone because we don't have all of the potential providers at a specialty and subspecialty level, having some access to larger systems for telemedicine, remote monitoring is one way that we can keep some of those patients in.
So this is a great opportunity to segue into the financial side. I don't know if we have any CFOs on the call or maybe CFOs interested in the financial aspect, but what we want to demonstrate here is really that financial value, right? As margins continue to be slim and difficult to maintain, we want to understand what is the potential opportunity here? Should we reduce that inpatient outmigration, and assuming that we keep in mind all of the nuances that JD has mentioned around, we need to make sure we have the appropriate staff and comfortability level. We need to work internally to figure that out. But we like to establish and demonstrate in our performance improvement work the value behind reducing this inpatient outmigration. And this is really based upon the concept of high fixed costs that exists within our rural hospitals. I know in our capstone presentation, this was touched on in detail, where there have been studies to show that rural hospitals have even a higher amount of fixed costs than perhaps urban counterparts. And that high fixed cost creates an opportunity for additional contribution margin or mini contribution margins throughout the organization. In this example, we looked at a hospital and worked with a critical access hospital to evaluate what might the financial impact be of increasing your inpatient census, which would include acute and observation, from roughly 9.5 average daily census to around 11. And we had evaluated this in the context of their capabilities, what the market indicated, et cetera. And so when we did that analysis, again, looking at the high fixed cost and the relatively low variable cost of an additional inpatient admission, it was determined that there was potentially substantial opportunity from a financial perspective. This one analysis indicates just shy of $550,000 if they're able to increase that average daily census to that amount. Now, obviously, there are lots of conversations around how do we make that happen? Can we work internally to strategize around that? It's not, we can't flip a switch and then all of a sudden we're able to get to a certain average daily census level. It requires a lot of work. However, if we consider that growth, there was margin opportunity in this case, and that's what the model showed. This model is particular to acute, so that would be acute and observation. However, this effect would apply for swing bed as well. Swing bed, we're going to be having a whole boot camp around that. And what we often see is there's substantial opportunity for hospitals to increase their margins by growing that swing bed census. So, and in this particular model, we just want to make sure it's clear for critical access hospitals. This takes into consideration a dilutive effect on our cost-based rates, which is a concern that we oftentimes hear is, if we increase volume, right, that's going to have an effect on our cost-based rates from Medicare, say, and we do account for that. But even when we take into consideration that dilutive effect, there's often still an enormous opportunity for a lot of hospitals that we do work with from a financial perspective. We can go to and this is just a demonstration of the potential financial impact for a non-critical access hospital. So the former example had to essentially take into consideration that cost-based impact. When we look at just a straight non-critical access PPS hospital, we can oftentimes identify that margin opportunity a little bit easier because you have a variable cost assumption and you bump that up against your net revenue per day. And so we're able to demonstrate that value here. Again, if we take a similar growth approach, and in this case, we looked at increasing that average daily census by about 1.2, there was substantial opportunity in that growth scenario. And so just a note that, as we're thinking about this, assuming that we have checked all the other boxes and really considered what we can handle as a rural hospital, we oftentimes find there's substantial financial improvement opportunity there.
Thanks, Wade. So that's really thinking about that acute side. And as Wade looked at it, you know, just growing by 600 days had a potential impact, even with the dilutive effect, had a potential impact of about $500,000, $550,000. If we grew by 600 days, or 657 days, that's still less than two additional patients on an ADC basis. If we've got a 25-bed unit and we've got a market that says, hey, the average daily census, for that market could be 17, and we're only doing 8, to go from 8 to 12 is a 4 ADC pickup. The numbers can be even more significant. So it is a significant opportunity. That's why it represented about 33% of the total performance improvement gains across the 30 hospitals where we looked at doing these projects. 14% of the performance improvement gains, though, were also from growing or expanding service lines. And so it's the same approach that we take when we're looking at the inpatient side, but start by understanding what outpatient volumes exist in the market today. Do we offer it? If we do, great, let's do some more of it. If we don't, then let's consider doing something different. What's our share of the market? Is it offered nearby? Can someone go 35 minutes or 45 minutes to the east or the west of us and have that offered? Uh, can we accommodate the growth? Again, we'll talk in a bit about sometimes the wish lists of, hey, we really want to offer this. We may want or need a linear accelerator in our communities, but the volumes are so small, the capital costs are so large, we don't have those facilities to accommodate that growth. Do we have the providers to deliver that care? Does it require us to bring a specialist in that doesn't exist today? Or do we have someone? Oftentimes we think, I'll give a specific example of GI services in a bit, but many of our communities have family practice physicians that also do GI, do colonoscopies. They've had some training in that, they're doing that. The market for the services may be there. The provider to do the services may be there. Now, what's the facility requirement to be able to do that? The number one opportunity, though, is to do more of what we're already doing. So capture appropriate ED patient volumes. If our ED patients are choosing to leave the community, let's ask ourselves why, right? Someone presumably in an emergency decides, not via EMS, but decides to get in their car and not come to you. There is a problem here. We have to understand what that is. Are they not coming because they wait for 3 hours in the waiting room before they ever get in? Are they not coming because every time they got admitted, they get transferred someplace else? So they decided to cut out the middleman and go directly to the other location. Why aren't we capturing more ED volume? I think that's, again, lowest hanging fruit. Growing the ED volumes, we already talked about, helps to grow our inpatient volumes, and also ancillary services. Where we don't have a high market share in ancillary services, what are the reasons? Is it that every time a provider tries to call and get into admits or have someone come for a CT scan at our hospital where we've got a CT scanner and it's sitting fallow because no one's using it, yet it's a 3-week wait to get them in? Or we can get them in, but we can't get them in today. We can get them in tomorrow, but only at this particular window, and that doesn't work. Schedule availability and convenience is a driving factor for capturing patient volume. If I can go someplace else, I might go someplace else if they can get me in faster. Cost is also a big one. And I know that we've got challenges relative to, high overall base costs in critical access hospitals. But it is something for us to think about. If there is a for-profit imaging center, 20 miles away or 100 miles away, where there's also a Costco and a this and a that, I may go get my MRI over at that other place cheaper than what you can provide it, and go to Costco, have dinner, do all of that still for less than what I was going to pay at your facility. Understanding your cost relative to where folks are willing to go is important. And then once we understand that schedule availability, convenience, and cost, then it's identifying what are any issues with our provider referral streams. Do we make it easier for our own providers to refer things into our hospital? Or are we not the easiest one and it's easier for them to call someone else? And if that's the case, that's a low-hanging piece of fruit that we should be addressing. So just like we did for the inpatient side, on the outpatient side, we want to understand the demand for services. Again, this is that same community. We've got 33,000 people living inside of it. Those 33,000 people generate 904 units of service, 904,000, sorry, units of service, and that's projected to grow over 5 years by 16%. Inpatient going down, outpatient going up. Common story we see everywhere. We can look at that by site of service. A lot of outpatient volume gets done at the private office, right? We're not going to magically turn that into something else. And in many cases, that's the right thing. We should have a lot of that. But often that's a lot of our labs and it's our medical exams and things like that. They don't all have ancillaries the same way that we do. In this example, the PSA expected to generate 176,000 office visits, 25,000 x-rays, 14,000 ED visits, 313,000 lab tests. Hold on to that number because Wade's going to come back to it in a little bit. This community, we're doing all of these lab things. Yeah, we may have to send a few specialty things out, but the vast majority of those 313,000 we could do. We could provide most of the 14,000 ED visits. What piece are we providing? So that's where we start looking at that. We say, okay, we've got 14,000 ED visits. We did 10,500, 74%, 75% market share. That's reasonable, right? Then it drops down. X-ray, 39% share. CT, 62. MRI, 25. Ultrasound. We're offering the services. We're capturing volumes. Why aren't we capturing more volume? That's the question for us. 313,000 lab tests. 142,000, we're capturing about half of that. We'll show an example with a little bit less capture in there. What are some of those issues? Talked about them already. Throughput, the wait was too long, so I went someplace else. Price, you're too expensive, my insurer sent me elsewhere. Or I'm on a high deductible plan, I'm paying out of pocket. I'd rather buy my MRI for $700 than give you $1,500. Have to understand that. My PCP sent me to XYZ location for lab work because it was easier, it was cheaper, it was whatever else. Where we can remove them, let's identify the barriers and look to remove them. If we're capturing close to 100% market share in some services and not in others, then let's ask ourselves why, particularly around ancillaries. If I'm capturing all of the lab, but not a lot of the imaging, let's see what lab is doing really well. Is the lab working directly with the provider offices to make sure we've got phlebotomists there? Or we're going and we're capturing, they're drawing and we're capturing them, bringing them over to our facility to do that, making life easy for our providers. That's the key on the outpatient side of things. So we'll talk about an ER specific example.
Yeah, so this is getting in again, just to understand what the impact could be here. To be very clear, this was a specific example based on data from a specific hospital. So you might not be able to translate this, say, I'm going to be able to generate this type of margin at my hospital. Every hospital is a little bit different. However, this will give you a sense of what you can do to really estimate that total impact. And so in this case, we looked at really a certain number of ED arrivals and the opportunity to decrease the left without being seen rate and make that maybe a little bit closer to what the benchmark is that we're trying to accommodate here. Also looked at improving the ED admission rate. As JD mentioned before, there are some targets we look at when we do performance improvement work. We tend to use 10 to 12% of ED visit admission rate to both acute and observation status. And use that really again as a benchmark, right? We don't want to make any assumptions until we've had a chance to really talk with a provider and better understand their situation. But we use that as a benchmark to gauge how we're doing. And so when we take into consideration all of those improvement opportunities, this really seeks to draw out a net benefit impact by considering technical charges associated with an ED visit. We have ancillary services built into this analysis as well. What might increased ED admissions result in terms of a financial impact? So again, just wanted to emphasize, instead of focusing on the specific numbers, just emphasize that this is really trying to get at 3 different pieces of improvement from being able to better utilize our ED And that includes direct reimbursement for an ED visit, right? We have that kind of initial, first form of payment for the service provided. We also get into potentially increased inpatient admissions as a result of our improvement in the emergency room. And we also need to consider the ancillary revenue that could come through an ED visit as well. And then any ancillaries that we would be associated with an inpatient admission that might come through. So when you factor all that in, again, when we looked at this specific example, we found there to be roughly 2.5 million in potential net revenue due to that ED improvement. And again, this will vary depending upon the hospital. If we have maybe a slower emergency room, as many of our rural hospitals do, we might need to adjust that downward and really figure out what is the true opportunity here. Maybe you have larger rural community hospitals that may have a significant amount of emergency room volume, but there's opportunity to find improvements there, and the net impact could be substantial as well. And so really just thinking about how can we, to JD's point, think about areas of opportunity within the emergency room because it can translate to real financial improvement. And then I believe
What
we
about
have
lab
another.
wage?
Yeah. So similar analysis for lab. And this is really trying to parse out the true variable costs that we talk about when we work with rural hospitals. Again, if we're talking about a time horizon of right now, that spot market decision, do we, offer another lab test today? Generally, the variable cost on that is quite low. And so in this example, we really demonstrated with a specific hospital the total cost. And what we oftentimes hear with working with hospitals is, this service line is, losing money, or, we lose money every single time we admit a patient, or we, do an additional lab test or imaging test. And we oftentimes will get data from the client that would say they take all of their costs associated with the department and just do a straight division of the total number of whatever it is units. So that would be tests. Maybe that's inpatient days. Maybe that's imaging tests, whatever it is. And when you have a lot of fully loaded cost, which is inclusive of overhead, it's inclusive of things that aren't truly variable, that can certainly make it seem like that you're losing money in this case. And so as you can see in this example, the column to the left represents the total costs. We see a lot of fully allocated costs being utilized to determine what it costs us to, say, produce a lab test. And if you take all the fully loaded costs, as you'll see in this example, assuming roughly 102,000 lab tests, the cost per test is about, $14, $15. And our revenue, which is more towards $8, is much lower than that. So the assumption here is that we're losing money, and so it's probably better for us to shrink and maybe not provide as much. You could make that inference if you looked at it at this level. But what we really tried to parse out here when you go to the next column are the relevant, the true variable costs associated with an additional lab test. And once you actually parse out that variable cost, you'll see it's much lower than this fully loaded cost number that we oftentimes hear referred to in terms of the cost for services provided. And now in that example, if you take into consideration the true variable cost, in this example, it was roughly $2 per test. And as a result of that, if we assume the revenue is going to remain consistent, that's actually a gain on a per test basis. So there's actually an incentive for us to grow volumes in this case. This is a really important and fundamental concept that we work with hospitals on to really understand that, again, volume growth is oftentimes a path towards efficiency, and looking at things from a true variable cost perspective is really important.
Yeah, I mean, I think, Wade, this is a perfect example to really be thinking about, those services that we're already providing, right? There is no scenario where we as a hospital are going to say, you know what, we lose all this money on lab, we're not going to do lab. We're out of the lab game. We're not going to do it at all. That's not realistic. If you're a hospital, you're going to have some component of lab, which means you are going to have salary, you are going to have supplies, you are going to have variable costs, and you're going to have overhead costs. And so, to Wade's point, if we just focused on not the things that we have to have just to be in the game, but if we focused on that incremental cost for every additional lab test that we're doing, remember the example of 300,000 lab tests in the market, there's an opportunity for us to capture another 75,000 of those tests. Why are we losing them? I don't know. That's part of the analysis we've got to dig into to understand why we're not capturing them. Maybe folks don't want to pay our fees, they don't want to do whatever, but let's think about that and then try to grow to success as opposed to cut to success. That's the name of the game. So Common pitfalls when we think about adding things that we're not doing today. Wade and I have been down this road before. We have a donor that has pledged to give us X dollars to put in Y service, so we should proceed. Well, that's great. So is the donor going to cover all of the costs on an ongoing basis? Or are they saying, hey, I'm going to give you $100,000 to like you to start an infusion program? At our last CHNA told us the community wants something, so we have to do this. Again, wants doesn't mean need. We go back to those kind of market assessment lists to understand at a service line level, what's the volume in the market? Is the juice worth the squeeze? I came in from a different facility. At my last one, we provided this and it did really well, so we should do it here. Are you in the same market? Do you have the same competitors? Do you have the same types of patients? Is the volume in the market the same? It may be that it makes perfect sense to do it, and you've got expertise in building and growing those programs, but understand whether or not the volume is really there. Our biggest competitor recently started providing it, so now we have to do it. Well, we don't have to do just because someone jumps off a bridge doesn't mean that you have to jump off the bridge. And I attended a presentation on this service, and it seems like a really good idea. When you go to a presentation on a service, oftentimes someone's trying to sell you something. And so, yes, it seems like a great idea to start a wound care program. Yes, there's probably a need for that wound care program. Are we going to be able to, make our ends meet in that? Those are considerations that we've got to be thinking about. So here's an example. I'd say start by completing a market assessment, understand the total volume. If we want to think about it, could it be viable financially, clinically, and operationally? As an example, if I'm in a community that generates 2,200 GI procedures, right? Colonoscopies, upper GIs, so on and so forth, I can accomplish that in a facility if I have 1 or 2 GI procedure rooms, right? If I'm just cranking, literally in and out, I can do 2,000 GI procedures in a room in a year, but that's super efficient. Unlikely that we're going to see that in a critical access hospital. So let's say we need 2 procedure rooms and maybe we have them, right? So we've taken the facility requirement out of things. At 25% share, we're going to start a new program where we believe we could capture 25% share. That's 550 procedures. It won't fill a room, but it could be enough to justify a part-time provider. Because the idea, if we have a market of 2,200 and we're not doing it today, the thought of getting to 100% market share is unrealistic. Let's not build unrealistic business plans. Let's start small and grow. So if we got 25% share, maybe it makes sense for a part-time provider. Maybe this is great information for our family practice doc that did some GI work, and they can start to fill some of that as we grow. If we're only using a room part of the time, can we use that space for other minor procedures while not being used for GI? May make sense. Let's say the community was smaller and the total market volume was 500 GI procedures. It's still a need. The community needs the colonoscopy. It's really important, right? Otherwise, I'm leaving and going someplace else. 25% share, though, would only be 125 procedures. That may be more challenging to justify bringing someone on site. Certainly more challenging to say, I'm going to build the room if I don't have it already. I'm not going to recruit a gastroenterologist. They're not going to come to our community to do that. But again, if I have the room, this piece of data may say, okay, I can have my family practice doc, my internal medicine doc that does some of this work, do those GI procedures. So it's just important, really, go to that market assessment, understand what is in the market first, then make your decisions from there.
Absolutely. Those are great, just excellent points to make, is really starting with the market. And then if you are able to look at the market and determine the need and make sure that we maybe have the type of volumes that would justify some sort of additional new service line, really the key there is to take it to the next level and do some sort of pro forma analysis from a financial perspective. Because even if, let's say there's a huge opportunity from a volume perspective, if that service is just not going to be covered by whoever it is, insurance or whoever it might be, then it's going to be a lot more difficult to stand up that type of program. Not impossible, perhaps, but it's still going to be much more difficult. And so one of the things that we want to consider, obviously, the anticipated volumes. If we're starting a new service line, we want to know what can we reasonably expect to capture, which again gets back to the market piece and understanding what the market can yield, first of all. And oftentimes when we're doing service line analyses, we find it helpful to do multiple volume scenarios because, as we talked about before, with the lower fixed costs, or I'm sorry, the lower variable costs associated on a per unit basis with many different service types, sometimes if we're able to model out, a low growth, moderate growth, high growth scenario in terms of volumes, it can make a big difference on what the financial outcome will be. Payer mix really important to keep in mind as well, especially when we get into areas like critical access hospitals with a cost-based component to their payer mix. It's really important to know, what that's going to represent in a given service line. The service location can make a huge difference. There are reimbursement implications to whether we offer a service in, say, a provider-based clinic versus a freestanding clinic where it's not associated with a hospital. A rural health clinic is another type of location that we're seeing growth in, and that has reimbursement implications in addition to other operational implications that we need to consider when we're doing a financial analysis. Supplemental revenue, as we talked about before, right? If we do have a donor who's willing to give some form of support financially on an ongoing basis, we'd want to consider that in our pro forma analyses. Expenses, again, really identifying what are the true fixed costs in terms of standing up a program, and then what are the variable costs on a per unit basis for growth in services in that particular area. So we want to be able to nail that down, make sure we have a very clear understanding of that, because that will impact the financial viability. And then and this is especially relevant for critical access hospitals, and we're going to talk more about the Medicare cost report in the next session, but there are implications to reimbursement if we start adding service lines, and it might be positive, it may not be so much, but we just want to understand that component and make sure we incorporate that into our viability assessment. But those are all things to consider.
So I know we've got 9 minutes before the top of the hour when Wade begins his next presentation. I don't know if there are any questions that have come through the chat already, or if anyone's interested in popping questions through the chat now. Certainly, you can feel free to reach out to either myself or to Wade after this session, and we would be happy to answer any questions that you have. I don't see anything through the chat. Brandon or Ashley, have you seen anything come through? Or Hillary?
We just got one question. It is all data driven. Where do I find the data?
So that's a great question, and it is the bane of many hospitals' existence. You can find your data. Certainly, when we start about the patient origin work, your data is in your own systems. When we think about finding the data for what is expected to be done inside of the market, there are sometimes state data sets. Various states have all payer databases so that we know historically what has been done, and then we can understand for a zip code basis what might we be able to attract. Many states do not, though, and so we'll look at we have a proprietary data set called Meritive. It used to be IBM Watson. Before that was Truven. SG2 is another one, the advisory board. It's important to make sure that we're looking at procedures and not kind of rolling all gastroenterology together. That might be visits and procedures and things like that. We just want to make it granular enough. The other way, if we can't access the data, if we don't have a subscription to a proprietary data set, is to do some research on use rates. Right? Understand, I can go to Google, I can go to ChatGPT. I'm going to ChatGPT myself out of a job now. Go to ChatGPT and say, what's the use rate per thousand for colonoscopies in Georgia? Right? And maybe we get an answer for that, or we can get something. Then I can apply that to what I believe my population is, and that gives me a sense as to what the number of those procedures might be. Same thing for the emergency department, same thing for things like X-ray. Again, proprietary data sets, if we can get them at a CPT level or rolled up CPT level, absolutely better than just doing a global use rate assumption, because use rates vary by zip code. And so we want to understand really what it is locally. Happy to follow up more directly. So shoot me a note if there's a specific question about a particular service.
Yeah, it looks
All
like
right.
there was a question that came
Oh.
through just saying that the data is typically older, and is there a way to work with that, given that we're dealing with an older data set in many cases? So
Yeah, I mean, I think that gives us some level of directionality, right? It gives us a sense that, 3 years ago, here's what our community generated. If we can extrapolate that to a new population number, again, it's not going to be precise, but none of this is going to be precise. I had someone once say to me, do you want to be wrong or do you want to be precisely wrong? Because you're not going to be right. So, looking at it and saying, are we, if it's 2,000 procedures or it's 2,100 procedures in a market or it's 1,900, that's kind of close enough for government work to make the decision. That's different than if it's 200 or 2,000. That's not really close enough. So we want to just try to get close before we drill down in there.
perfect. I
All
am
right.
not seeing any other questions, so I think we're good. Just wanted to make folks aware that we do have additional sessions. Again, the cost report opportunity session will be directly after this, so in about 5 minutes or so here. We're then going to follow it up with the swing bed boot camp, which will be on October 16th. In the chat, you'll notice a number of links, or there should be a few different links coming through for you to register in case you're interested. But the swing bed, again, October 16th at 11 a.m. Eastern. And then we've got a couple more following that with times as well. We're going to have our 340B and revenue cycle sessions as well. And so you'll okay, there we go. So the 23rd
Sorry.
at 11 Eastern, no worries, for our 340B, and then revenue cycle on October 30th at 11 a.m. Eastern time as well. So we hope to see you all at these sessions, and thank you for joining us. Been a great time.
Thanks very much, everyone. Go log into Wade's cost report session and learn
Great.
all about the Medicare cost report. Thanks so much, Wade. Have a good one.
Yeah, thank you. All right, bye.
Cheers.